Hey everyone, it's Hartley. This is my presentation on extracorporeal membrane oxygenation, also known as ECMO. Um, so let's start by talking about what is ECMO. It's sometimes called the heart-lung machine. It's also sometimes called extracorporeal life support, ECLS. So when people talk about a patient being on life support, I know we've mentioned in class sometimes that means pressor, sometimes that means uh, fluid drips or something like that, but a lot of people, I think, refer to life support as being ECMO or the ECLS machine. So what does it do? It's essentially a heart and lung bypass. So if there's one thing that you take away from this presentation, hopefully the analogy I like to make is that what dialysis does for the kidneys, the ECMO machine does for essentially the heart and lungs, or sometimes just the lungs, but we'll talk about that in a minute. So it takes the blood out of the body. It does the function that that organ would normally do. In this case of the lungs, obviously it's removing CO2, adding oxygen, and then it returns it back to the body. So that's what ECMO does, kind of in a nutshell. The core indications are the main times it would be used. It's sometimes used during cardiopulmonary surgeries, like things we might be doing a heart transplant or something like that, where obviously there is no heart or there might not be any viable lungs for a few hours, so during surgery. And it's also used in patients that have profound heart or lung failure, systemic inflammatory responses, and sometimes now potentially it's getting used in some situations during cardiac arrest. It gives you a chance to figure out the H's and T's and focus on what's going on with the patient without necessarily worrying about their lack of oxygenation and their lack of circulation. So that's ECMO in a nutshell. Now, in order to talk about ECMO and to understand it a little bit more deeply, you kind of have to know that there's two key types of ECMO. You'll hear them referred to as VA or VV. Basically, it's veno-atrial and veno-venous. And they're a reference to where the blood is taken out of the body and where the blood is reintroduced. So in veno-atrial, that's the image on the left there. So the blood is removed from the venous system at the vena cava, and then it's reinfused back to the body at the aorta. So in this case, it's taking the blood out just as it enters the heart. It's skipping the right side of the heart, it's skipping the lungs, and it's essentially skipping the left side of the heart and just being reintroduced right back into systemic circulation. So that bypasses both the heart and the lungs. With veno-venous circulation, again, we're removing blood at the vena cava, but this time we're reintroducing it into the intrajugular vein, so it's going back into the venous system. A little non-traditional to have freshly oxygenated blood entering the right side of the heart, but the idea is that this is used for respiratory-only bypass, so if we want the patient's heart to still be working and still be pumping blood and doing that work, we might put them on VV. You can kind of think about it, I know we talked about different ventilator modes as some being kind of heavier and some being a little lighter. I think patients that end up on VA, veno-atrial ECMO, tend to need the most support, and then oftentimes as they're being weaned down to a little bit less support, they'll be switched over to VV. So essentially starting to get the heart back involved, making sure it's beating well and has good contractility and everything like that. So obviously these are invasive. When we're taking blood out of the vena cava, you might be thinking of like a central line or something like that. These cannulas are really big and beefy for taking all the blood out and introducing it back in. So they're typically placed in the operating room. And they're also generally not considered a long-term therapy. I've seen studies that talk about they should be used for like a week or 10 days. I've also heard case studies of people who have been on VA ECMO for 25 days, and then they get weaned down to VV, and then eventually a ventilator, and then they can go home. But it's not a long-term thing. Generally, you would use this to help the body ride out some kind of inflammation or a process that the body just needs a little bit of a break from. So that gives you a little bit more detail about ECMO. So in the next slide, we'll talk about the nursing responsibility. So the ECMO machine itself is not normally managed by the bedside RN. Typically, it'll be a physician, or there are dedicated folks called perfusionists that get training in how to operate these ECMO machines. Some facilities I found do have training that will allow a bedside RN a chance to manage it. But usually in those situations, there'll be one RN that's managing the ECMO machine, potentially multiple ECMO machines for multiple patients, and there'll be a separate RN that's assigned to the patient for all of the other assessment and nursing duties. So it's a pretty team-based approach. So that's important for the nurse to know. The nurse obviously is responsible for monitoring and assessing the patient. So, as we would do normally with a patient in the ICU, we're going to be taking ABGs. We're going to be looking at their blood oxygen concentration and their CO2. The nurse might not be taking those ABGs. That might be a respiratory therapist, but you're going to want to look at those numbers. Another important thing for the nurse to assess when their patient's on ECMO is looking for blood color changes. So normally we'd expect the venous blood that's being pulled out of the body to be more of a dark red, kind of that venous color, and then as it's being reintroduced to the body, coming out of the ECMO machine, it's been reoxygenated, so we'd expect it to look brighter red, arterial, that arterial red color. So if the blood being removed is bright red, if you're seeing arterial blood being pulled from the body, it's possible that the two cannulas, I'll just jump back a slide here real quick, it's possible that the two cannulas might be too close together, and so you're just sucking blood out that you just put back into the body, so it's not actually being circulated. So that's something that you'd want to assess for. There's also a lot of weird stuff that goes on with circulation in the body when you have ECMO running. Because of where the catheters sit and where the blood's being pulled out and put back in, the blood that's being reintroduced can really kind of mess with the left ventricle. So obviously the left ventricle, as we know, is supposed to push blood out into systemic circulation. But if you have VA ECMO and the blood's being reintroduced past that left ventricle, you might notice there being some weirdness with the pressures in your arterial line. You might not see the normal waveform with dicrotic notch and stuff like that you'd expect. So that's something to definitely keep an eye out for, that the cannula might not be in the right place. And it's also important to talk about this sort of north-south syndrome, basically where the blood is reintroduced. You might have deoxygenated blood that hasn't gone through ECMO getting pumped up to some parts of the body, whereas the oxygenated blood that's being reintroduced is being reintroduced a little bit too far down, and so it's not getting out to all the different branches of the arterial system. So you might have cyanosis as the tissue gets ischemic. You also might have limbs that are pale, cool, clammy, just generally ischemic. So that's definitely something to keep an eye out for. And then a big thing is trying to keep the patient sedated to avoid accidentally having them, pull their cannulas out. I have read stories about patients who were not sedated, and they're just told to keep very still, but it doesn't seem very wise. I'm not sure how often that's done, but we'll talk more about that here in a minute when we get to the risks and complications. And then the other big thing, as with all critical care patients, is making sure we're looking at their skin integrity, trying to do limited mobility without kinking any of the cannulas, and then just doing the standard anti-delirium bundle if patients are going to be sedated for a while on this, making sure that they're not having these other kind of issues that we typically associate with time spent in the intensive care unit. So looking at risks and complications, the big kind of most obvious one is disconnection of the cannulas themselves. A lot of these ECMO machines are set to pretty high. I mean, they're essentially replacing cardiac output if you're on VA ECMO. So that's like 3 to 6 liters of blood per minute that's flowing through it. I mean, the normal is generally 4 to 8 in a healthy person, but a lot of these machines will run a little bit lower just to allow some circulation. So 3 to 6 liters per minute of blood is obviously a lot of blood coming out really fast if those get disconnected. So that can be very dangerous. We've talked about recirculation, so if the cannulas get too close together, then you're just sucking out the blood that you just put back in and it's not getting to circulate through, so that can be another thing you need to watch out for. And then there can also be kind of a sucking down or kicking. I've heard different ways this is described, but it's essentially because there's so much blood being pulled out of the patient rapidly, again, thinking that 3 to 6 liters per minute, the suction force on that cannula can kind of cause the vein where it's being collected, or in some cases even the right atrium of the heart, to kind of suck down and collapse around the cannula that's pulling the blood out. So imagine you're vacuuming, with a hose, and you happen to brush over a piece of cardboard. That's going to suck and stick to the end of the vacuum and prevent there being proper flow into the vacuum, or in this case, flow of deoxygenated blood into the cannula. You can have issues with the ECMO machine itself. So if there's some issue with the pump, then that's not going to be circulating blood. You're essentially putting the person in like a total heart failure if they're not getting that circulation. Or if there's some issue with the oxygenator, then you might be pulling the blood through it and putting it back in the body, but you're not actually pulling off the CO2 and adding oxygen. So that's obviously very problematic and not really sustainable for very long. So that issues with the machine itself would generally be managed by the perfusionist or by the physician, but that's something the nurse obviously has to keep an eye out for to know, if they need to send out a page or something like that to get help to the bedside quickly. And again, with any machine that takes blood out of the body and puts it back in, you're thinking about clotting, you're thinking about potential DIC, different kinds of embolisms, so like air embolisms, things like that. That's similar to what you'd expect with like a dialysis machine or something like that as well. And then the other big thing, which is very common in the ICU, of course, is bloodstream infections and the risk of sepsis. So when you have these giant cannulas that are very similar to a central line that's hanging out right in the right atrium, if some kind of pathogen is introduced into that cannula, it can travel straight into the heart. Same thing with these cannulas for ECMO. You just have to make sure you're really cautious about keeping a sterile field and making sure your lines aren't getting tangled or bumping the bed or things like that, and just keeping the whole area really clear. So I have my APA resources listed, and I also just threw in an extra slide at the end in case you want to keep reading about it. The Wikipedia article is really useful. There's also a great site that everybody should know about. It's called WikEM. It's basically like a Wikipedia for emergency medicine, which is great because it's basically geared to be like crash courses on things. Like if you're working in the emergency department, you don't have time to get a PhD and all these different things. You can just kind of look something up quickly. So they have a pretty good article on ECMO that goes into it. And I also found a 20-minute talk from an RN who talks about essentially the RN responsibilities and the interprofessional team and stuff like that. So I included that link as well if you want to watch that. But those are my sources, and hopefully you got a better sense of what ECMO is, how it works, and how we should manage it as nurses.